and also for like, sharing information with friends and others that might be interested in our series. So this is the positive behavioral interventions in community and community settings, family and a caregiver series, and is being supported through IBT by several grants and also by KU Medical Center with the Cigna grant as well. So it's really a team effort that we are able to create this training series for family members or others who can benefit from this information. So when you are joining, you are being muted, but if you need to, we welcome, this is a collaborative communication. So if you want to chat in, or if at some point you want to speak, please feel free to unmute yourself or chat in the chats. And we would love to see your faces. So if you are in the setting, you can keep your camera on. We would love that. But we understand if you're not in that setting as well. Also, if you wish to receive a completion certificate, and you can definitely please make sure that you have your name, first name and last name on the chat. And also, we collected email addresses, but there's some glitch. So if you are wanting to have completion certificate, or you want to hear more information from us, because we do send out like the Zoom link, like the YouTube link of all the conversation we had, or resources that the speakers may have mentioned. So please put your first name and last name in the chat, and also your email address. Okay, next. So at this point, I'm going to turn over to Ali. She's going to help us introduce our great speakers today.
Okay, so I will admit I wrote this introduction for Amy, but I can improvise on the fly. So good afternoon, everybody. Thanks for joining today's PBS series on health relations, sexuality, and consent. With us today is Amy Tucker and Stephanie Luther. Stephanie and Amy have been members of the Dual Diagnosis Treatment and Training Services team since 2014, and Stephanie actually serves as the director for the team. As a part of this team, they have traveled all over the state of Kansas to provide behavioral consultation and training services to individuals of all ages and diagnoses. They have both finished the ABA course sequence through the Florida Institute of Technology and plan to sit for certification in the fall of 2021. So let's welcome Amy and Stephanie to our Parent Cafe series.
I like to do the little hand clap up there. So thank you, Amy and Stephanie. I just want to make sure that that everybody knows that you are eligible for a certificate of attendance for today, for coming to our presentation today. But at this point, it does not satisfy the BACB requirements for type 2 CE. We haven't set that up yet. And as our Parent Cafe series, it's geared more towards parents or those professionals that are working directly with parents. And so in the future, we'll work to have it satisfy the BACB requirements, but this one does not. All right, Amy, take it away.
All right. So just want to start that, the information is current. The information was taken from peer-reviewed journals, and interventions are specifically ABA based as we get into the presentation. So as Ali had kind of introduced, I'm Amy Tucker. I have a Master's of Arts and I'm a behavior consultant with the Parsons Outreach Team. And this is my supervisor.
I'm Stephanie Luther. I'm the director of the Parsons State Hospital Dual Diagnosis Outreach Team. It is a mouthful, so you can call us Parsons, you can call us Outreach, whatever is easiest. I have a master's degree in counseling psychology. I am duly licensed in Missouri and Kansas, and I am very proud to say Amy and I have completed our ABA course sequence through Florida Tech, and we'll be sitting for the board exam for our certification in probably about a month.
Yes.
So
So hopefully we will soon be adding BCBAs to our mouthful of qualifications. So we work on a small outreach team within the state of Kansas. We're a team of 6, and we handle the state, and we work with individuals with intellectual or developmental disabilities, and then usually pretty severe behavior problems. So we consult throughout the state with agencies, schools, families working to increase appropriate communication and then decrease, obviously those challenging behaviors. And so this training kind of sprung out of that work, and that specifically questions and concerns from parents, families, schools, agencies about sexual behavior, about sexuality, about consent, about relationships. And that's really kind of where this idea came from. So today's agenda, we're going to be defining sexuality. We'll be talking about boundary crossing behavior, and then sexually inappropriate behavior, and then potential interventions to address those challenging behaviors. We will also talk about, how to have those conversations with your child or children about healthy relationships, and then resources that parents and caregivers can use to assist with that. We will also, yes.
Do you realize you're not presenting?
Nope.
Yeah, it's like sharing screen. I don't think we are, you're probably having something in front of you. We don't.
I am so sorry. Yes.
No, that's okay.
We had a brief connection issue, so I will
reshare.
Yes.
I didn't want you to go through the whole thing thinking that we were all.
No, I so appreciate that. Yes, I definitely need to know that.
So now we can see your PowerPoint slides, but it's still
Okay.
in.
Yep, I am. Okay. As you can see, I am super tech savvy. Okay, that's not what I meant to do. Bear with me, everyone. Oh my
Down
gosh.
at the bottom, if you go
Yep.
all the way down to the bottom, you see that little screen at the bottom. Yep, that'll present.
Okay, so now you guys can see the agenda, yes? Okay, thank you, Linda. And then we will be defining consent and providing resources for how to discuss and teach consent to your child or children. So going through, sexuality, we're not talking about how somebody identifies, if they are straight, queer, bi, lesbian. We're not talking about sexuality in that sense. We're talking about sexuality in the sense that it's somebody's body, it's the bodily sensations, and then we're learning and teaching those appropriate and inappropriate ways of touching other people. It can include sexual activity or the expression of sexual interest, but it doesn't necessarily have to be, because again, some people are interested in those types of relationships and other people may not be. We also really want to emphasize that, individuals with an IDD, they may have some limited opportunities to kind of learn the rules for what's appropriate and what's inappropriate. And that can be for lots of different reasons. One of those being that they may not always be around their neurotypical peers to receive some of that feedback. Oftentimes, they may be in smaller classrooms, they may be around other students or individuals who also have special needs, which means they also may lack some of that awareness or ability to communicate appropriate boundaries. Sometimes, kind of like what Linda had mentioned at the beginning of, sometimes those conversations can be really uncomfortable about having sexuality, about being interested in sex, about touching, other people or themselves, and they may not always be using the correct terms for body parts or bodily sensations. Some individuals require an enormous amount of support as far as being dressed, toileted, showering, other hygiene related issues. And so they may not already have some of those natural kind of boundaries or expectations for privacy because they need assistance for that. And some individuals may not hit those developmental points where they maybe needed assistance with toileting when they were little, but then they work towards a different level of independence and no longer need that, therefore giving them some of that privacy that comes with aging. They may not experience, again, some of those milestones at the same time as their peers. And so other individuals may just be a lot further ahead, so to speak, than they are as far as maybe what they are interested in. And, sometimes there's conversations that may begin, too late, in the sense that challenging behaviors have already occurred. They've already been reinforced. And so talking about it after those things have happened can be especially difficult. So when we're talking about inappropriate sexual behaviors and boundary crossing, specifically inappropriate are those behaviors that are performed within an environment that the behavior is deemed as unacceptable by societal standards. And again, that can vary based on with what's okay within a family, because every family has kind of a culture. Religion can obviously play a factor, and then other cultural factors of where a family lives within a state, where they live within the US or outside of the US. So again, lots of different variables within that of what's deemed okay or not okay. Based on the research, though, they had specifically defined and described the following list of inappropriate sexual behavior or boundary crossing behaviors. And so those are kind of the ones that we are focusing on. So those include disrobing, public masturbation, touching own genitals in public, touching other people without their permission or consent, just publicly discussing sexual topics, sexual arousal to atypical objects or individuals, which again have some potential serious consequences, masochism, stalking, paraphilia, or coercing others into sexual behavior. And I don't think that this can maybe be underemphasized, but it's especially important to address those because there can be injury, legal problems. Some individuals can be restricted from community outings or placements because they are not able to be deemed appropriate or safe to be around other people, and sometimes, experience some of that social rejection. So again, may temporary, or it could more permanently restrict some learning as well.
So I'm sorry, Amy and Stephanie, do you, I was going to ask this before you started, do you want to entertain questions now as you present?
Sure.
Or would you prefer that we hold them to the end?
Yeah, that would be fine to go.
Oh, good, because I have a question.
Okay.
I was called in to consult on a case. The young man was 22. This has been like, a long time ago. And he was in a day service, and he would spend the majority of the day in the restroom at that facility. So it wasn't really a public restroom, but it, was public in terms of, everybody else in the facility used that restroom. And he would spend the day in there masturbating. And so I came in and I said, and you can tell me if I was wrong. I came in and I said, we need to teach him an appropriate place to do that and not an appropriate place to do that. Mm-hmm. And they said that we couldn't stop him because that was restricting his right as an adult to engage in those kind of behaviors. And I disagreed with it, respectfully disagreed with them, and said, if he was a neurotypical individual, he would be arrested. Mm-hmm. And so by permitting him to spend that time in that public place, engaging in what we would consider inappropriate sexual behavior, we're setting him up for incarceration and to be labeled then as a sexual perpetrator.
Sure.
What do you think?
I would agree that it would not be something that we would say is an okay location to masturbate. Our usual position, because again, we hear this all the time with schools and agencies and families. I I guess to me, I view that a day service environment is equivalent to a school or to a workplace, and that's not an appropriate location to be engaging in masturbation. So it's our position too is masturbation is perfectly fine and normal, and that's something that an individual has a right to do, but there are appropriate parameters that need to be given as far as where. I mean, and usually we would say a private bathroom at home, or their bedroom, you know, with the door closed. But that's not something that they would be engaging in other locations. Do you have anything?
Thank you.
Okay. Yeah, we would have 100% supported you on that, Linda, because
Okay.
yeah, I mean, you're exactly right. And one of the things that we really try to emphasize to teams is we want to treat our individuals just like we would treat anyone else, you know, and so we want to treat them with the same dignity and respect, but they also should have the same boundaries, parameters, and essentially consequences for those aberrant behaviors. So yeah, we would agree.
Thank you.
Yes. And I think that that leads into kind of the next thing, which is that, you know, inappropriate sexual behavior affects those around them. Because if that is something that was, if somebody else has been violated, threatened, witnessed, I mean, if a peer had walked into the restroom and seen the individual that you were consulting on engaging in masturbation, that's not something that would be acceptable either. And so they have a right to be able to enter a public space at their day services and not be exposed to somebody else's genitals or private behavior. And then of course, making sure that we're consulting with any medical professionals, schools, obviously including, you know, any caregivers or parents in those conversations and interventions. So Stephanie is going to take the next couple of slides going over some of those interventions that can be helpful and applicable for addressing those inappropriate sexual behaviors.
So of course, you know, in order to appropriately intervene on some of these inappropriate sexual behaviors, the most important piece, which is also oftentimes with this specific type of behavior, the most difficult, is to know the function. Why are they engaging in these inappropriate sexual behaviors? You know, just trying to kind of guess at things and throw things out there and see if they stick. These are some severe behaviors that could have some very serious long-term consequences. So it's not really something we just want to throw things at and see if it works. However, with that being said, trying to determine the function of inappropriate sexual behavior through a functional analysis sometimes isn't ethical. We would not want to try to elicit those behaviors. So it can be very difficult. And a lot of times you just have to, depending on the nature of the inappropriate sexual behavior, you have to really rely on a functional behavior assessment, meaning those interviews, naturalistic observations, and just really trying to look at the variables, the situations in which they're occurring. And we a lot of times just have to depend on the caregivers, teachers, staff that are, you know, reporting these behaviors in order to try to glean as to what the function may be. Because again, you know, trying to do a functional analysis on an individual who maybe masturbates around children is not ethical. So we would not want to put them in those situations. But just to kind of go over a little bit about the functions that could be at play with inappropriate sexual behavior. Of course, the four main functions. It could be attention. A lot of times we have clients, in particular, we have noticed a lot of times clients who, you know, if they disrobe in the middle of the grocery store, boy, they get a lot of attention for that. And so if we start to see that increase every time they go into the grocery store, it could very likely be that the function of that specific inappropriate sexual behavior is attention. So, of course, we would want to minimize attention for the inappropriate sexual behavior and really have a thick schedule of reinforcement for providing them attention for the things that we want to see them doing, like walking and appropriately in the grocery store. It could also be escape or delay. In particular, when we consult on school-age children, one of the best ways to get out of tasks or classes or things that you don't want to do is to masturbate in class, because you are immediately removed from the classroom. So, you know, in those situations, we would obviously want to recommend teaching them how to ask for a break and allowing them to do it in an appropriate way. And then if they were masturbating to get out of class, maybe we take them into another area, another classroom, but guess what? That work doesn't go anywhere. It could be tangible. So maybe they are masturbating to gain access to something. Maybe they are disrobing. Maybe they are rubbing up on people. We tend to see that tangible is less likely as a consequence for, or as a function for inappropriate sexual behavior, although it could be possible. So of course, providing opportunities for them to earn the things that they want for appropriate behaviors. And then the last one, which is honestly one of the most difficult to try to determine if that is the function, is automatic reinforcement. So the thing that we typically teach our teams, parents, staff, when we do think that it's automatic reinforcement that's at play, is just to teach them those parameters. So just like you were saying, Linda, of when and where it is appropriate to engage in these sexual behaviors. Or if it's, disrobing or touching people inappropriately, that, teaching them that that's not ever appropriate to do out in public or to touch people without permission. One of the tools that we often use specifically for individuals who will masturbate in inappropriate areas is a masturbation social story. And I will tell you, it is fairly explicit. Because sometimes it's just a matter of they don't know when and where it's appropriate to do that. And we always want to make sure that we are pre-teaching those expectations and walking them through, this is normal, this is healthy, it is fine, but this is where you do it. And this is, how you clean up afterwards. And we don't talk about it to other people, and all of those little pieces that sometimes individuals that we work with simply have not been taught and do not understand. A few different interventions that we will also use sometimes for intervening on inappropriate sexual behavior, specifically if you have the individual, the student maybe who is doing it to get out of things, is some simple instructional revisions. So perhaps we are rearranging, modifying the classroom, perhaps we are reducing requirements, making the task less aversive, so making it more fun to do that task. Maybe we are reducing requirements and offering more frequent breaks, doing the pre-MAC principle, offering them those really highly preferred activity choices after they complete at least a part of the task and then bringing it back to them. So sometimes just some simple instructional revisions can be very helpful. We may also look at manipulation of those motivational operations where we're going to try to alter the value of those potentially reinforcing stimuli. So for example, if it's a person who's attention motivated, and we have noticed, again, in my previous example, the individual who likes to disrobe in the grocery store, we might want to really, really, really pile on lots of positive attention before we even go to the grocery store, so that it makes that reinforcing stimulus of getting attention for disrobing at the grocery store less likely or less reinforcing, because they hopefully are somewhat satiated on attention before they even get to the grocery store and don't find it to be as valuable. Non-contingent reinforcement is another intervention that you could use. So just providing access to reinforcement independent of the challenging behavior and really making sure that it's a very fixed schedule of reinforcement. So whether that's attention, whether that's access to tangibles. We might also look at doing a DRA, a differential reinforcement of alternative behavior. So this is, of course, when we are identifying an acceptable replacement or alternative behavior for the inappropriate sexual behavior. And we're providing lots and lots of reinforcement for that alternative behavior. And then on the flip side of that, if there is the inappropriate sexual behavior, we're withholding the reinforcement for it. So we're pairing it with extinction. Differential reinforcement of other behavior is another intervention that you could use. So of course, that's when we're providing the reinforcement within a set amount of time after it has passed without the challenging behavior at that time. So this can be effective for behavior maintained by attention or access to tangibles. And again, one of the key pieces to the DRO, because if you don't know what you're going to try to reinforce or what behavior you're going to appropriate behavior you're going to focus on, perhaps you can inadvertently reinforce some other behaviors along the way. So it is really important for teams to clearly understand, after this amount of time without any inappropriate sexual behavior, if this person is engaging in, let's say, property destruction or something, we probably don't want to provide reinforcement right at that moment, because we may inadvertently then reinforce some property destruction, even though we're not reinforcing the inappropriate sexual behavior. Extinction, of course, as we were just saying, is also a part of the DRA. A lot of times what we are looking for, especially when it's an inappropriate sexual behavior that is crossing boundaries for somebody else, or could have some serious health or legal consequences, we might have to put it on extinction. And that might be one of the first things that we're looking at, in addition to, of course, trying to add in reinforcement for the appropriate behaviors that we want to see more of. It can be very difficult if the inappropriate sexual behavior is maintained by automatic reinforcement, because we can't take that away from them. It's an internal component. However, there are some different things that you can do. For example, a lot of times if we have somebody who is masturbating in public, disrobing, those types of things, we might recommend something like a wrestling singlet for them to wear, or some more restrictive clothing. And again, kind of to your point, Linda, earlier, some of these things, of course, are restrictive in nature, and they might have to go, through the Human Rights Committee before a team can even implement it. Or the last one here being punishment. So of course, that's a procedure that we put in place to decrease the future frequency of the inappropriate sexual behavior occurring. And that might look like timeout, it might look like restraint, blocking, restitution, or sometimes there might be a response cost factor put into like a token economy system. So next, we're going to talk a little bit about how to begin those conversations about healthy relationships.
Can I jump in for a second?
Yes, by all means.
I had another young man that we worked with, and he was nonverbal.
Mm-hmm.
And we put in SDS Delta. So for those on the call who are maybe not have as much of a background in that, what that means is it would be something like he was nonverbal, like a green circle and a red circle. So when the red circle was present, it meant no masturbation was available. When the green circle was present, it meant that it was okay. So we would put the green circle in the bathroom with the door closed, or we'd put it in his bedroom with the door closed. And then when we were out in the kitchen working, the red circle would be there. And so we taught him how to be able to discriminate when it was appropriate and when it was not appropriate. And so there's ways that you can do it. It made me think of that when you were talking about the social story, because social stories are great if we have really good receptive, if the kids understand what we're talking about. If they don't, we can use some of these other more basic processes to be able to teach them when it's appropriate and when it's not.
That's a great point, Linda. Yes.
And then one other thing before we move on, I have a question. Do you see a difference between, and it may be one's masked, between the number of females that come to your attention versus the number of males? And you may talk about that later. I don't know.
We're not actually, that wasn't something that we're already going to cover. I would say that we definitely have a lot more males where this is a concern or an issue. I think part of that is, generally autism is more prevalent in males. That gap is lessening, but we do tend to get more male referrals. I think my personal experience is the parents or caregivers of females are less likely to talk about it, or they are more likely to just an absolute shut it down, that they want no discussion, no teaching whatsoever about where or when. For example, the masturbation is probably one of the most common things that we have to deal with. And usually parents of girls or females are not interested or open to that a lot more often than parents of boys or male.
Yeah, I think I would agree with you that, and that's definitely a cultural thing, I think. But having worked with several little girls, I know that they do the rubbing, right? And
yes,
at probably just as frequent a rate as males sticking their hands down their pants, right?
Yeah.
Yes. And I think in our experience on the team as well, that I think females sometimes exhibit some of those challenging behaviors as far as rubbing or masturbating on objects at a younger age. But again, there seems to be, like you said, kind of a socially acceptable or an expectation for males to engage in that behavior, and it's not the same for females generally.
Thank you.
And so, yeah, we do our best to provide education and normalize, and just both, males and females, or both genders, or the spectrum of genders, it's perfectly normal and acceptable for them to do that. Again, we just want to put those privacy kind of parameters around behaviors.
Yeah, I like that term, normalize,
Mm-hmm.
because it's a normal behavior. So
Yeah, absolutely.
So the next thing we're going to talk about is how to begin those conversations about healthy relationships. And by relationships, we're not, exclusively talking about romantic relationships. It could be friendships. It could be working relationships, simply, peers at school, at day services, roommates at home. So, we're talking all inclusive about those relationships. So regardless of if an individual has an intellectual or developmental disability, most people crave connection. They want to feel that relationship with others. They want to build trust. They want to have shared interests with others. Sometimes we have individuals, I'm thinking particularly on the spectrum, who don't do a lot of parallel play or engage a lot with their peers. And so it kind of, a lot of times, it's kind of portrayed to us like, well, they don't have interest in other people. That may be true, but it may not be true as well. So teaching individuals about healthy relationships is important for everyone, regardless of if they're verbal, nonverbal, what their level of intellectual disability is, or if they're actually coming to you and talking about friends. So just to assume that they don't want to have them because we don't see them engaging in it doesn't necessarily mean that they don't. So it's important, I guess, for everyone to be talking, about these healthy relationships. And they can be really hard to navigate for any individual. I mean, hard for me to navigate sometimes, and especially for those ones who have difficulty with the social interactions, or, not being able to verbally communicate. Sometimes that can be, a huge barrier to being able to navigate relationships with other people. One of our individuals that we're getting ready to do a consultation on primarily uses American Sign Language. Most people around him don't use American Sign Language. And, if you just think about how complicated that will make everyday interactions and relationships for that individual, so there's just a lot of extra barriers sometimes that we have to navigate through. Also, a lot of times individuals with an intellectual or developmental disability are in smaller special education classrooms. They might not receive the same sex education or the same education about relationships that their, same age neurotypical peers will receive. It's also important to remember that physical maturation might not align with the developmental maturation. So we might have, a 16-year-old who is developing and having physiological responses to things, but is still interested in much younger interests. And so parents might think, well, yes, they are going through puberty. I can tell through, physiological changes and whatever, but I don't think they're interested in these things because, they're still wanting to watch cartoons every day or whatever. So don't assume that those two things are going to match up, or that just because they aren't expressing interest, that they're not still having those same physiological responses to puberty development. And so it's important just to kind of keep those things in mind. Some parents or caregivers avoid having these conversations with their children because they're afraid that even providing any of this information or providing the wrong information might lead to something terrible. They might become hyper-focused on a subject or a behavior and then thus create more challenging behavior. We've definitely worked with families where we've had individuals from the 10-year-old to 15-year-old realm who were engaging in some inappropriate sexual behavior, but they didn't even want us to address it. They didn't want any kind of teaching or interventions to be utilized. They just wanted it to go away. So I'm sure you all know, if you don't intervene on it, teach, talk about it, it's not likely to just go away. Helping an individual identify and recognize healthy relationships can also help protect them against unhealthy relationships, both currently and in the future. If we don't talk about what boundaries are, if we don't talk about physiological responses to things, if we don't talk about values in a relationship, whether that's a friendship, a romantic relationship, working relationship, how are they to know what's unhealthy? So start talking when they're young and keep doing it. We always encourage parents to, have these conversations early on. And of course, you have to adjust them for, their developmental level. You would probably have a different conversation with a 16-year-old than you would a 4-year-old. But it's important to ask questions and to be a resource so that kids can come to you with questions. And there's a ton of different ways that you can do this. One of the ways that can be very helpful is to try to think about their unique interests and then relate these conversations back to their unique interests. Maybe they have a favorite TV show, a favorite movie, a favorite sports team, and you can use those as ways to talk about the different social interactions that you saw between these two friends, or between this boyfriend and girlfriend, or this girlfriend and girlfriend, boyfriend and boyfriend. So you can use different modalities. It doesn't have to just be a didactic sitting down and having a conversation about it. And as you guys know, sometimes those types of conversations don't go very far with some of our individuals. So you have to meet them where they are and find what they're interested in and use those modalities as ways to have these conversations. And keep explanations simple and short, adjusting to the developmental level of the individual. So we don't want to, again, have that kind of didactic, speech about, what relationships are and what they should be and placing our own values on them. It should be more interactive, but keeping those explanations simple and short. And then, as Amy was saying earlier, normalize and use those anatomically correct terms. It's, very common for people, especially with young kids, to use not anatomically correct terms. And sometimes I think it's, parents feel uncomfortable using those terms. But one of the reasons why it's so important to do that is because later on, when it comes time to, maybe they're in a situation and they have to give consent for what they are okay or not okay with, if they are using terms that maybe the other individual doesn't know what that means, that can make giving consent or obtaining consent very difficult. And then again, use multiple methods for teaching. So maybe we're watching videos, maybe we are, and there's so many resources, and we'll get to those in a little bit. But there's so many different resources that you can use to talk to younger children, adolescents, young adults about what healthy relationships are. I know here in the Kansas City area, there are several different social skills groups that also specifically work on healthy relationships and provide those opportunities for individuals with an intellectual or developmental disability to learn it and practice it. You can also use, of course, articles, books, pictures, role playing, modeling, those what if scenarios, what if your friend did this? How would it make you feel? What would you do? How would you respond? Those types of things. And then discussing values, expectations, and listen to theirs. So it's perfectly fine for parents to talk about their own values and expectations, but it's so important to encourage in the individuals, what are your values? What are your expectations? What do you like to get out of a friendship? What would you expect to get out of a romantic relationship? And really have that be, an interactive process. Modeling and teaching social skills, including self-esteem, is incredibly important, because without self-esteem, sometimes it's hard to establish and adhere to your own boundaries, and therefore it can make giving consent even more difficult. So sometimes it's a matter of, we're really going to model for our individuals, our children, what we think is an appropriate way to establish our boundaries, and feeling confident about, establishing our boundaries, and that we're worth having boundaries and having other people respect our boundaries. And that all is a part of self-esteem. See the individual as someone who is capable and worthy of healthy relationships, including romantic relationships. We have a lot of individuals, young adults, middle-aged adults, teenagers, who will verbalize to us that they want to get married one day. They want to have that romantic relationship, and that's something that's important to them. We've actually worked with a few really, really great agencies across the state who have even, nurtured those romantic relationships. I know it's been several years ago, but I definitely had a case where it was an adult who had been dating their partner for a couple of years, and, consistently, because sometimes we have the serial daters. But these two individuals, they had gotten engaged, and it was really important to them that they got to get married. So the agency actually set up for them to have it wasn't a legal marriage, but they had, a ceremony to represent that. And I thought that was really cool that the agency was really supportive of that, because it was something that was really important to them. Encourage independent thinking, action, decision-making, and boundary setting. So again, in order to be able to give consent, to understand what, is important to you, what you value, and to be able to set boundaries and expect others to respect those boundaries, you have to encourage independent thinking. So we don't want the individual who becomes vulnerable to being persuaded to do things because it was never encouraged to them to have that independent thinking. And these may change over time. Of course, our boundaries may change within relationships even. What we're okay with at the beginning may not be okay at the end, or vice versa. So it's important to continuously have these conversations and talk about them. And then give them a variety of social situations and people to be around and help create that support network. That's also important to, help individuals generalize to various settings, various people, but also to understand that certain social situations, maybe you might be okay with certain things in certain social situations, but not in others. And it's not, usually just a black and white type of thing. I'm okay with this in all situations, because that's typically not the case. It's okay not to know the answers and to figure it out together, or to look up additional resources. I think one of the reasons why parents a lot of times are afraid to have these conversations is because they're afraid a question will be asked that they don't know how to answer. It's okay to not always know the answers. None of us do, right? So figuring it out together and being empathetic and or questions and providing additional resources to them is 100% okay.
So the following is a list of various resources that can be found online. The first one is Nicholas Mayo in St. Louis. He's got a great website. He is both a BCBA and is very well versed in addressing and having inappropriate sexual behaviors. He's a big advocate for individuals with disabilities to be in relationships, to be in control of making those decisions and educating them. There's also a webcast or a podcast, ABA Inside Track, and I included the specific episode number, and it's an interview with two individuals who, again, are proponents and experts in sexual education and sexual well-being. There's also, I included the American Association for Sexuality Educators, Counselor, Therapists. So that's working to find a local resource for your child, if that's something that you're needing. The parentcenterhub.org, that is specifically about relationships and geared towards teaching that to individuals with disabilities. There's also a resource from Massachusetts. And then the last is a website, the Sex Ed for Social Change. So lots of different resources available to you, depending on what you're looking for, what you may be after. So The last section that we're going to be covering today is consent, and I'm going to show a video.
If you're still struggling with consent, just imagine instead of initiating sex,
The
you're making,
video's not showing. The sound
you
is
say,
coming
hey,
out.
would you like a cup of tea?
Okay.
And they go, oh my God, fuck yes, I would fucking love a cup of tea. Thank you.
I'm so sorry.
Then you
One
know
second.
they want a cup of tea. If you say, hey, would you like a cup of tea? And they're like, I'm not really sure. Then you could make them a cup of tea or not, but be aware they might not drink it. And if they don't drink it, then, and this is the important part,
I'm so
don't
sorry,
make
guys.
them drink it. Just
Um,
because you made it doesn't mean you are entitled to watch them drink it. And if they say no, thank you, then don't make them tea at all. Just don't make them tea. Don't make them drink tea. Don't get annoyed at them for not wanting tea. They just don't want tea, okay? They might say, yes, please.
okay, so we are going to try this again.
That's kind of you.
I think it's because you have to share the, when you say share your screen, there's a thing in there that says share video. So when you,
Nope.
I can't do it.
And then when the
because-
tea arrives,
Oh my
they actually
gosh.
don't want the tea at all.
It might be best to unshare and reshare your screen.
Yeah,
Thank you, everybody, for your patience. I'm really embarrassed.
You got this.
Okay, so let's try that. And we are going to go to the beginning. Is
If you're
this,
still struggling with
are you guys seeing it now?
no, you have to share it.
Yeah.
And so when you say share, there's a option there under advanced. So say share, and then up across the top of that little share thing, there's a, ta-da, there it is. Ta-da.
consent, just imagine instead of initiating sex, you're making them a cup of tea. You say, hey, would you like a cup of tea? And they go, oh my God, fuck yes, I would fucking love a cup of tea. Thank you. Then you know they want a cup of tea. If you say, hey, would you like a cup of tea? And they're like, I'm not really sure. Then you could make them a cup of tea or not, but be aware they might not drink it. And if they don't drink it, then, and this is the important part, don't make them drink it. Just because you made it doesn't mean you are entitled to watch them drink it. And if they say no, thank you, then don't make them tea at all. Just don't make them tea. Don't make them drink tea. Don't get annoyed at them for not wanting tea. They just don't want tea, okay? They might say, yes, please, that's kind of you. And then when the tea arrives, they actually don't want the tea at all. Sure, that's kind of annoying as you've gone to all the effort of making the tea, but they remain under no obligation to drink the tea. They did want tea, now they don't. Some people change their mind in the time that it takes to boil the kettle, brew the tea, and add the milk. And it's okay for people to change their mind. And you are still not entitled to watch them drink it. And if they're unconscious, don't make them tea. Unconscious people don't want tea. And they can't answer the question, do you want tea? Because they're unconscious. Okay, maybe they were conscious when you asked them if they wanted tea. And they said yes. But in the time it took you to boil the kettle, brew the tea, and add the milk, they are now unconscious. You should just put the tea down. Make sure the unconscious person is safe. And this is the important part again. Don't make them drink the tea. They said yes then, sure, but unconscious people don't want tea. If someone said yes to tea, started drinking it, and then passed out before they'd finished it, don't keep on pouring it down their throat. Take the tea away. Make sure they're safe, because unconscious people don't want tea. Trust me on this. If someone said yes to tea around your house last Saturday, that doesn't mean they want you to make them tea all the time. They don't want you to come around to their place unexpectedly and make them tea and force them to drink it going, but you wanted tea last week. or to wake up to find you pouring tea down their throat going, but you wanted tea last night. If you can understand how completely ludicrous it is to force people to have tea when they don't want tea, and you're able to understand when people don't want tea, then how hard is it to understand it when it comes to sex? Whether it's tea or sex, consent is everything. And on that note, I'm going to go make myself a cup of tea.
That's awesome. I like that.
We're getting her back going. Sorry, guys.
All
We
right.
use Microsoft Teams, so this is a little different for us.
So
Ta-da. Oops.
Oh,
was there.
no.
Now it's gone. That's okay. You just have to
I
share
was
it.
right. Okay. Are you guys seeing my screen again? The
Yes.
consent okay, perfect. So yes, that video is kind of a silly, easy way to communicate that. There is a younger, the video below that, the hyperlink below that is a video that can be used for younger children. It does not have the cursing. And it also is about kind of body autonomy of like, you get to decide who touches you. And so that's kind of like, if you want to give somebody a hug or not is the example used in that one. So there are different options depending again on your audience for that. So defining consent can feel a little tricky. I know that that's maybe a word that's become more common or kind of a buzzword about people talking about consent, especially as things in our culture and society in the US have shifted dramatically in the last couple of years. So defining consent, it is a clear and enthusiastic yes. It is an active, voluntary, and verbal agreement. It is a process and a conversation, and it can always be withdrawn. One of the articles used putting this together was, it had the phrase in it that consent is a state. It is a temporary state rather than a trait, meaning it is a temporary place that you are in. It is not something that is this blanket thing that consent is always okay. And I think, again, that video really described it well, where you can want something the day before, you can agree to something the day before with a different person, a different time, and changing your mind is absolutely okay because circumstances have changed. And also something to note that temporary state can be altered by medication. It can be altered by alcohol or other substances. And kind of the reverse of that is also, it can be enhanced as we provide more information and education to individuals for them to really understand what that looks like, what consent is to them. Consent is made up of 3 different pieces, which is that knowledge, rationality, and voluntariness. So knowledge encompasses lots of different things, but some examples, being able to label body parts. So again, what are they consenting to if they're not sure what body parts you guys are talking about or an individual is talking about? So again, that kind of loops back to making sure that correct body terms and anatomically correct language is being used. Being able to identify sexual behaviors, understanding when and where it's appropriate to engage in those, and then when it's not. So all of those would be pieces to make sure that an individual has knowledge and is able to give consent. For that rationality, again, ability to evaluate the risks and benefits of a sexual situation and then make a decision based on that. So that can include maybe the sexual acts. It could include risks of maybe pregnancy or, a sexually transmitted infection or disease. So again, it's understanding both of the risks and some of those rewards of, yes, it might feel good, but this isn't a situation that I'm comfortable with right now. And then again, how to effectively communicate that to the other individual or other individuals. And then that voluntariness. And that really is related to some of that self-esteem discussion that Stephanie had talked about earlier of ability to decide without coercion. So not worrying about hurting somebody's feelings, not worrying about feeling pressured into something, especially if maybe they've previously agreed to it and they're not comfortable at this time engaging in a behavior. And then also being able to communicate that clearly and effectively, and also what to do if they need or want to leave a situation, of how they can choose to do that. These are additional resources for discussing and teaching consent. That first link is where I had received that consent video, and they've got lots of other great resources, and they specifically have broken them down into categories based on early education. So roughly kind of a developmental age of 5 or younger, elementary aged individuals, middle school and high school. So again, kind of being able to kind of pick and choose resources depending on the age and appropriateness for the individual you're working with. Teachconsent.org is another great resource. They have got lots and lots of tools as far as videos, discussion guides. They have games, handouts, activities, all sorts of different things. And then within that, the last link is a great resource specifically for talking about relationships. And that's specifically the state of Virginia is who had put that on. So wrapping up today's presentation, just want to kind of reiterate those key takeaways. Inappropriate sexual behavior can definitely be a serious, challenging behavior, but there are ways to address that, to decrease once we understand kind of the reason that an individual is engaging in that behavior, and then finding and utilizing the best behavioral interventions to address those challenging behaviors. And again, don't be afraid to ask for help, consult with other professionals, whether that's an individual school team, other caretakers, parents, medical professionals, and so on. Nobody has got all of the answers. Also really want to emphasize that, individuals with an intellectual or developmental disability should receive information and education about their bodies, sexuality, and opportunities to explore those as they grow and develop. And then making sure that we are teaching and modeling consent and healthy relationships on an ongoing basis. Conversations, again, you can't have them too often, and they should be developmentally appropriate. That is our list of references. And if anybody has any additional questions, we are happy to take those.
I would love to stay on and pick your brains. Unfortunately, I have to jump off for another meeting right at 1 o'clock that I'm hosting. Do you guys have contact information that you could share for perhaps follow-up referrals?
Absolutely. Yeah. I can share that with, Allie's definitely got it. And then, yeah, Kayla, I can make sure, we've emailed, so you've got my contact information, and the link to referral for our services specifically is underneath that signature. But yes, that would be great if you guys want to share that or have further questions. Thank you so much. It was a wonderful presentation on a topic that people are often reluctant to present on, right? Right. So I really appreciate it. Thank you.
I know we only have like 1 minute, but can I ask a question, Amy and Stephanie? So I guess, what's your suggestion when you talk with parents or other family members who might have different cultural or religious expectation on this, particular sexual behaviors? Mm-hmm. How can you get them on board? And yeah, would love to pick your brain on that. I've definitely had that experience. Where individuals will say something along the lines of, I don't agree with that, or I don't believe that, or that's not okay within our family or our religion. Usually my response has been to kind of give a general bit of information and say, I understand that, and that's your choice on whether and how this is addressed. I have professional concerns that things could become worse, or these are potential directions that the behavior could go if unchecked. And then I've usually kind of said, if you want to think about it, we can talk about it later, and I will bring it up at another point, just so it's not necessarily putting a parent or a caregiver on the spot to agree or to dig in their heels maybe and say, I'm absolutely not discussing this anymore.
and try to just reiterate it or bring it up at another time. I've definitely had parents who've said absolutely not, under no circumstances. And I've just kind of had to leave it with, if that changes, or if there are questions later, I'm here and I'm happy to, address that.
Yeah, I mean, exactly, just like Amy said, and depending on what the behavior is in particular, one of the things that I like to just kind of gently address is the potential consequences that that individual and the family could be, encountering. And from a behavioral perspective, it would be best to try to address it now before it gets to that point. But again, like Amy said, obviously these are very difficult conversations for some people to have. And so just kind of, again, leaving it with, I completely respect your values on this and your beliefs on this. I am concerned about potential consequences, and these could be some of those consequences. So if you come to a point where you would like our help in addressing it, we're here.
Yeah, absolutely. That makes a lot of sense. Thank you both, Amy and Stephanie, for this wonderful presentation. Very, very informative, and also the resources shared. With that being said, I think we're 1 minute over. So thank you all for being here. And again, thank you for this wonderful presentation.
All right, you're
Thank
welcome.
you.
Thank you.
Thank you.
Have a good day.